All right. Hi, everybody. Welcome. We're really happy that you're here with us today. Please, if you have any questions, go ahead and you can put them in the chat, and we're going to try and answer some of those at the end. It is my great honor to introduce Dr. Kathleen Motil, who is a professor of pediatrics in the Department of Gastroenterology, Hepatology, and Nutrition at Texas Children's Hospital, Baylor College of Medicine. In her extensive career, she's received awards from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, the Food and Drug Administration, and the Texas Dietetic Association. She's an author on more than 100 research publications, many focused on MECP2 related disorders, and we are thrilled to have her share her expertise with us today. Thanks for being here, Dr. Motil.
Thank you. So good afternoon to all of you who are watching this program. I'm sorry that we really can't look at each other face to face, but I will go ahead and begin. I want to talk about nutrition and gastroenterology for the MECP2 Duplication Syndrome. If I may have the next slide, please. So for today, I want to present some of the current information that we have about MECP2 duplication. And it really comes from the questionnaires that we obtained from many of you during the times that we had conferences here at Baylor on this particular topic. Then we'll talk about some of the nutritional gastrointestinal problems that I certainly see in MECP2 duplication syndrome. And then I'll talk about some treatment strategies for the nutritional and gastrointestinal problems that we see. The next slide, please. So I want to begin with what we know about the growth and nutrition status of the children with MECP2 duplication. I've summarized on this particular slide data from 30 children. You can see that 50% of them or so were younger than 5 years of age, and the other 50% were older children and adolescent children. We know that in the children with MECP2 duplication, about a third of our children have short stature, which we consider less than the 5th percentile, but the average height percentile on the growth charts is on the 25th percentile. In contrast, we know that the BMI, which is how I look at the weight relative to the height, we know that most of our children, more than 3/4 of the children that we looked at, tended to be a little on the chubbier side, really at the cutoff of where we'd like to see kids at the 85th percentile on the BMI chart. We do know that about 17% of the children with MECP2 duplication are in fact underweight, meaning they're less than the 5th percentile. And we also know that about 10% of the children with MECP2 duplication are in fact overweight, greater than the 85th percentile. And for me, both of these two categories, underweight and overweight, are to some degree problematic because they really do interfere with a good quality of life and a healthy child. We know that about half of the children with MECP2 duplication will use formulas, and we know about almost 1/3 of our children will have gastrostomies to help with the chewing and the swallowing. The next slide, please. From the perspective of the gastrointestinal problems, we know that at least, well, close to 90% of our children have a feeding problem. And it's really because of some combination of either chewing difficulty or swallowing dysfunction. More than half of the children that completed the, or parents whose children, of the children who completed the surveys told us that their children had either chewing difficulty or swallowing difficulty or a combination of both. More than 1/3 of the children take longer than 30 minutes to eat a meal, and more than 1/3 of the children do have episodic choking with their meals because they have difficulty swallowing. We know that almost 2/3 of the children have gastroesophageal reflux. 20% of them have gastroparesis, which means delayed tummy emptying, and that becomes relevant because it too contributes to gastroesophageal reflux. And 20% of our children have fundoplication, which is what I call the tummy tuck. It's a surgical procedure that helps to reduce reflux in the children when it becomes severe enough that we have difficulty managing it. The next slide, please. We know that only 3% of our children have gallbladder disease, and this number is similar to the frequency that we see in the MECP2 deletion problems, that is Rett syndrome, atypical Rett syndrome, and mutations that include MECP2 but don't fit the classical diagnosis of Rett syndrome. Those 3% of children have had cholecystectomies as part of their treatment. Gas bloating is present in about half of the children that were surveyed, but only 10% do we really see visible aerophagia with the swallowing of the air. We know that more than 3/4 of our children have constipation, and once again, this particular problem is very common and one of the biggest issues that we have to deal with in the MECP2 mutation syndrome problems. 80% of the kids have a lot of straining, more than half have hard stool. And so these are the kinds of issues from my perspective that are common when we talk about nutritional and gastrointestinal problems in the MECP2 duplication syndrome. Now, these data have been accrued from the conferences that we've held in the past, and they represent really the small number and the beginnings of information that we gathered at the times of the conference. I wanted to take this opportunity to mention that we here, particularly Dr. Pillivan is going to be sending out in the not too distant future a survey via the web. And we are hoping that many of you will take the time to answer the questions on the survey, because we really would like to update our database. The way we learn about MECP2 duplication syndrome is from all of you who are really the experts. Your children help us to know more so that we in turn can help you more. So I'm hoping that all of you will take the time to complete the survey when we're ready to embark upon our next endeavor. So if I can have the next slide. Oh, and I'm sorry, I forgot to put this one in. We did do some queries about bone health. We know that about 10% of our children with MECP2 duplication have low bone mass. We know that nearly half of them have had a fracture in the past. 3/4 of the children take vitamins that include vitamin D. And I'll get back to this later because vitamin D does become very important. We know that only half of our children consume at a minimum or a maximum 2 glasses of milk a day, and this will become important. And we know that about half of our children consume some sort of commercial formula. Seizure medications are used by about 40% of our children. And we know that about 3/4 of our children, 2/3 of our children are ambulatory, either with or without assistance. vitamin D levels, we only have a few children who had vitamin D levels drawn. Most of them were in the normal range, although some of them teetered on the low normal range. And from my perspective, I really like to see children whose vitamin D levels run actually a little higher than what the Institute of Medicine considers normal, because our children have special needs. So having said that, again, these are all parts of questions that we've gathered from our conferences in the past, and it's time we now update the information that we have. Now I'm ready for the next slide. So the first thing I want to talk about is the growth and nutritional status of the children with the MECP2 duplication. We know that the patterns of growth actually vary quite a bit. We know that children can have normal height. We know that many have short stature. What we don't know is whether or not the children have genetic downsizing at puberty. In the children with Rett syndrome, for example, we know that at the time of puberty, the growth velocity slows, and it slows rather early so that they never really achieve their full adult height potential. We don't know if the same thing is true in our children with MECP2 duplication. We don't know whether our children with MECP2 duplication have less muscle mass than body fat, as we see in our children with Rett syndrome. So this is another unanswered question that we have. We know that poor growth, which is one of the more important aspects of the growth picture, is caused by inadequate dietary intake relative to the growth needs, but we don't know how much of that poor growth is related to genetic downsizing. When children have inadequate dietary intake, parents will always say to me, "Oh, my child eats all the time." But really what they are missing is the point that the children may eat all the time because they have a relative inefficiency in their chewing and swallowing skills. They really are not normal when we tease apart what do the children really do. We know the children can have gastroesophageal reflux. We know they have constipation, and we know they have seizures. And all of these other issues oftentimes interfere with their feeding patterns, and they contribute to poor intake of their diets. We don't know anything about malabsorption in the MECP2 duplication, but if it's like my children with MECP2 deletion, it is unlikely that the children have any kind of intestinal malabsorption that would contribute to their poor growth parameters. Next slide. I wanted to comment a little bit more about the chewing and swallowing problems, because oftentimes as parents, you live with your children, and so sometimes what I see as poor chewing and swallowing skills really is normal for all of you, because you see your child as your child functions. So I put this slide on the screen. It is a still picture of the swallow function study that we obtain at times in our children. And what you can see here is that this particular child has swallowed some barium-laced liquid, and this is the mouth, and the barium has gone into the back of the throat and is now coming down to the point between the breathing tube and the feeding tube. And what you can see is that the barium has pooled and gotten stuck at a point where the breathing tube separates off from the feeding tube. And so when people do this kind of study, we're looking for a number of different things. First of all, we want to know if the children can chew. Do they have good jaw movement that goes up and down, particularly when they're eating things like a cookie? We want to know what happens to the tongue. Does it move sideways? Does it move food from the front to the back of the mouth? Many times the tongue is really ineffective in motion. And so you have the inability to really generate a good bolus of food that can go to the back of the throat so that you can swallow. We know that many times liquids and even some solids, if they're soft, they will pool in the back of the throat in the little pockets that you have between the breathing tube and the feeding tube. And if the child cannot protect him or herself, we know that the liquids oftentimes will penetrate into the breathing tube, called laryngeal penetration, or you can have the liquids go farther on down the breathing tube and we have frank aspiration of the liquids. Therapy for this kind of problem is really very limited. Your OT and your speech therapy folks are usually the people that we send your children to because we want them to have therapy for the oral motor feeding skills. Our motto is, if you don't use it, you lose it. And so we do want all of your children to go for those therapies. Sometimes we find that your physicians or your schools don't particularly want to provide the therapy because your children haven't made progress, and that's a no-no. For us, if your child is sustaining and maintaining the skills that your child has, that in itself is progress. So OT and speech therapy are extremely important for the chewing and swallowing dysfunction. Next slide, please. The BMI, as many of my folks know, is my gold standard to look at nutritional status. And again, I put on this particular slide a copy of the body mass index chart. The body mass index chart reflects the ratio of the child's body weight to his or her height. We know that normal represents the 25th to the 75th percentile. So that's the lines between spaces between these two dark lines, the 25th and the 75th percentile. For me, the trigger to look twice at the child's nutritional status occurs whenever I see a BMI measurement that is either less than the 55th percentile, rather, as you see with the dot in this particular chart, or a dot that occurs actually above the 85th percentile, which is in this vicinity and on up. We know that we have to think about alternative feeding methods if the BMI is less than the 5th percentile. And those alternative feeding methods include oral supplements, sometimes nasogastric tube feedings, but more often than not, gastrostomy tube feedings. And we know that for those children who are overweight or over the 85th percentile, we have to think seriously about dietary energy reduction to help the children reduce their weight relative to their height. Next slide, please. Low bone mineral content and low bone mineral density, we really don't have good numbers in our children with MECP2 duplication. At one point in time, we attempted to do some studies using ultrasonography, but we found that the measure of just using ultrasound was really not good enough compared to the DEXA scans. The DEXA scans are difficult to do because we really need to have our children lie very still and not move underneath the DEXA scanner. And that's often difficult for our children to perform. So we really don't know what the prevalence of low bone mineral content and low bone mineral density is in our children with MECP2 duplication. We suspect we have increased fracture risk, but we really don't know on a large scale whether our children have fractures a lot or not. We do know that fracture risk includes poor dietary intake of things like calcium and vitamin D. We know that some anticonvulsants will aggravate the possibility of fractures. And we know that children who are immobile and have difficulty walking certainly will increase the fracture risk. One simple way of looking at whether or not bones have good or poor bone mineralization is a simple X-ray of, for example, the hand or the wrist, because we can tell if the bones have osteopenia or low bone mineral deposition. But it's not a quantitative test. The DEXA scan by far and away is the best way to tell if we have poor bone mineral density. But again, the children need to be very still, and if they're not, it's garbage in and garbage out. Dietary treatment strategies are quite limited, but what we do know from our studies in our girls with Rett syndrome, dietary calcium and vitamin D become very important. The next slide, please. When we talk about the recommendations for calcium, we refer to what we call the dietary reference intakes for age, which are part of the Institute of Medicine's information and recommendations. The recommendations change with increasing age, and they run the gamut between 700 milligrams per day to 1300 milligrams per day. The simple way to remember that is within each of those age groups, each of those numbers represent an increase from 2 cups a day to 3 cups a day to 4 cups a day in adolescence of something in the milk and dairy category that will provide adequate calcium. So for example, milk and yogurt are both very good sources of calcium in the diet. One serving of milk, which is 8 ounces, will give you about 300 milligrams. So you either need 2, 3, or 4 glasses of milk a day. 1 cup of low-fat yogurt is a little better than an 8-ounce glass of milk, but remember, the yogurts that you buy in the store these days are on a reducing size plan, and many of them are already down to about 4 ounces a serving. 1 ounce of American cheese is another good way to think about it. So 2 ounces of American cheese is a good serving size of calcium in the diet. For those children who won't drink milk or won't eat yogurt, we will at times use pill-type calcium supplements. But we know that the pills are not absorbed quite as well as your dietary foods, your dairy and milk type products. But you must be careful with those supplements, because again, we know that the calcium supplements have variable amounts of calcium in them. So you've got to be sure to read the labels when you're picking up the calcium supplements in a pill form, if that's what you end up using. Next slide, please. Vitamin D, again, is very important because it helps to get calcium across the intestinal tract when you are eating foods that contain calcium. We know that there are several risk factors for vitamin D deficiency, including darker skin, kids who don't go out into the sun, which includes many of our children with special needs, and children who take anticonvulsants. Some of the anticonvulsants compete with vitamin D, and therefore you don't get the benefit of vitamin D. Again, sunlight is a very good source of vitamin D, but our children often aren't out in the sun. And milk in the United States is supplemented with vitamin D. The vitamin D recommended intake is across the board for everybody, including adults, 600 units a day. However, when I see my kids with special needs, I often will tell parents I prefer to up that amount a little bit, between 800 and 1,000 units a day. Again, because the children often don't drink enough milk and because they don't go out into the sunlight. The Academy recommends that children consume as much as 4 8-ounce glasses a day, which will give you roughly about 400 units. So you know that you have to make up a little bit more from a supplement. We will always supplement our children if their vitamin D levels are less than 20 nanograms per milliliter. And in fact, I really prefer my numbers to be greater than 30. Next slide, please. Gastroesophageal reflux, we consider to be passage of the stomach contents back into the esophagus. We know that it's caused by poor motility of the esophagus, the lower esophageal sphincter, and delayed stomach emptying. My parents will tell me my child might be irritable, my child might be awakening at night for no good reason and be fussy. We know that the children can vomit or have wet burps, or can just have simple regurgitation of milk or other liquids. Some of my children will actually refuse to eat. And then we see the respiratory issues where the children have extra coughing, or they can in fact even wheeze when they have reflux. We might do upper GI series to get a visual appearance of how high the reflux occurs. We can do pH probes, which means we put down a small tube in the nose and down into the esophagus and leave it there for 24 hours. Or we can do a gastric emptying scan to see how well the tummy does or does not empty. Next slide, please. There are a number of approaches to help with reflux that include the diet, the position of the child when eating, and then medications, and on a rarer occasion, surgery. With respect to the diet, we want our families to stay away from spicy foods, anything that has caffeine in it, so coffees, teas, chocolate, stay away from, and certain citrus foods, so things that have orange juice in them or things that have tomato in them can sometimes aggravate reflux. We know that we like to keep children upright for 30 minutes after eating. And if you can, elevate the head of the bed 45 degrees by putting something like a cinder block under the legs. That's a good choice. Although a lot of times the children are mobile, and so they very often move around. The medications can include simple antacids, which block acid. But we also have other options such as histamine receptor blockers like famotidine or Pepsid. And what I consider to be the Cadillac drugs, the proton pump inhibitors, these are things like omeprazole or Prilosec, things like lansoprazole or Prevacid, or things like esomeprazole, Nexium. In addition, there are some other medications that fit into the class of prokinetic drugs. These are things like bethanechol or erythromycin we will use when we need additional help to reduce the amount of reflux or delay gastric emptying. Surgery for reflux is called a fundoplication. That's a tummy tuck, where we wrap the tummy up around the lower esophagus to minimize episodic reflux. We seem to be doing this type of procedure much less these days because earlier on, when we didn't know as much about our children with MECP2 mutations, we weren't quite as aggressive in using our medications. So now we tend to be very proactive about treating reflux and delayed gastric emptying so that we can minimize any complex surgical procedure. Next slide, please. Gas bloating by definition is gas trapping in the stomach, in the intestines, and it's really tummy distension, which gets worse over the course of the day. It's caused by air swallowing, and it's aggravated by constipation because you end up having a lot of bacterial overgrowth in the lower colon, which produces a fair bit of gas from the bugs. The symptoms are basically air swallowing, burping, tummy distension, abdominal pain, passing a lot of gas, and in some instances, diarrhea. We can do simple tests like an abdominal x-ray to look at the pattern of gas bloating. For children who might have celiac disease, they produce a fair bit of gas. We'll do a simple blood test. For children who have the specific parasite Giardia, which is endemic in places like Texas, for example, we will do parasite tests. And if we really want to know if our children have bacterial overgrowth, we will do something called a lactulose breath test. Next slide. Again, the treatments rely on diet and some medications. We will make sure that the children aren't getting a lot of high carbohydrate beverages, anything that has sorbitol in it, such as, for example, some of your juices. And for people who consume a lot of beans in their diet, or for example, our black beans have a lot of gas producing compounds in them. So it's wise to be careful of what you're eating. If you happen to be lactose intolerant, you can always add the lactase enzyme tablets, or you can drink lactate treated milk. We have gluten-free diets for celiac disease. There's basically one type of medication which is good for gas, and that happens to be anything that has simethicone in it. Some of my folks, however, like the Beano preparation, which some people will use for the high bean diet. Sometimes I will write for an antibiotic called metronidazole. That we'll use, it's specific for the gut and helps to reduce some of the bacterial flora. We can't use that microbial all the time because it does have side effects, but on an intermittent basis, it may be helpful. Some of my folks will swear by probiotics. Others don't think they do anything, but the specific bacterial products that contain Lactobacillus reuteri or rhamnosus, for example, are good ones. Some of the ones that contain the bifidobacterium, those are other good ones. And last but not least, laxatives are very important because we know that any child who is constipated, that only aggravates some of the gas bloating issues. Next slide, please. And then last but not least, constipation is difficulty having bowel movements. And as I said, this is one of the biggest problems that we deal with. The causes are most often functional. They can be neuromuscular, and certainly my children with neurological disorders fall into this category. Some of my kids who have thyroid problems or endocrine problems can have issues with constipation. And certain drugs, particularly phenytoin from the seizure category, will add to the problem of constipation. The symptoms that we can see obviously are infrequent motions, less than twice a week, hard stools. Some of my children will have blood in the stool. The children will strain with the evacuation of their stool. They may have abdominal distension, abdominal pain. They may be passing lots of gas. They can get urinary tract infections. They may refuse to eat, and they can even have vomiting. For my children who have this sort of problem, one of the simplest things that I will do will be something like a rectal exam, because I need to know how to manage the children. On occasion, I will do an abdominal x-ray to look for how much impaction the stool of the children have throughout the colon. And for those children where we really do have a concern about a problem such as Hirschsprung's, we might do a barium enema. Next slide, please. The treatment approach really hovers around three issues: the diet, medications, and physical activity. For my children with neurological problems, my families will always say, I would like to do natural things. But I will tell you that the natural sorts of things that really invoke dietary issues are often not enough for my children. Fiber is always important. So fruits and veggies, good cereals like shredded wheat or anything that has fiber in it in the cereal preparation is good. Anything that has sorbitol in it. So we're talking about are things like prunes, which are first choice. Pears would be a second choice, and any other fruits would be sort of on the lower list that contain sorbitol. Those would be good things that would help with constipation. Again, my probiotics, if they work, that's terrific. If they don't, then I don't use them. They tend to be expensive, so it's up to the families to sort of try them out and see them. If you think they work, good. If they don't, then I stop them. When I talk about medications, I talk about the softeners, the pushers, and the pullers. Those are my three categories. The softeners are usually our first choice, and those are the common simple things like the polyethylene glycols, the Miralax, the Glycolax types of varieties. These are great drugs. They're very safe. If you give them by the mouth, they come out the bottom end. But for some of my children, they don't work. They tend to produce sticky stools. They tend to produce a lot of gas. So for some children, they simply aren't a good choice, but they really are the first choice that we use. Some other drugs in this category that we might use are things like mineral oil or lactulose. But again, there are pros and cons to many of these drugs. The pushers that are my first choice go-tos are things like milk of magnesia, the liquid, because I can regulate how much or how little my children need. Another choice would be something like senna, but sometimes it's hard to find. It can be expensive in the liquid version, but it is there as an alternative choice for a pusher. There are other drugs on the market that you can buy that have different mechanisms of action, but these drugs are often relegated to individuals who are older than 18 years of age because they come with black box warnings. And so I really don't use very many of them I don't use them in children, actually. I might use them in my older adults. But the problem is that you really, I don't think, gain any more mileage with the expensive drugs. And oftentimes they are not covered by your insurances. And so we really do stick with the tried and true that we use in the smaller children. When we talk about pullers, I'm really talking about suppositories, and those run the gamut of the simple bisacodyl type drug or something simple like I'm having a senior moment, your glycerin suppositories. There is, however, one drug out there on the market that Medicaid will cover, and it's really actually in the classification of enemas, but it does contain a medication, docusate, and that particular drug is enemies. A number of my families like it in the category of what I call the pullers, because it tends to be effective when you need that. And as I have said earlier, the constipation issue really becomes more of a problem as my kids get older. And so sometimes we do find that we resort to things like the enemies to help the children with their issue of constipation. If my children really do become impacted, which is something we hope we never see, we have to resort to enemas, or else we have to resort to nasogastric lavage, which is putting a tube in through the nose and dripping over a prolonged period of time, something like our polyethylene glycols. And last but not least, physical activity is important. So if your children can get up and stand or walk with or without support, we encourage you always to keep your children active, because that too in and of itself is a simple thing that you can do to help with constipation. So my final slide, please. We know that nutritional and gastrointestinal problems are common in the MECP2 mutations. Our goal is to tell our parents, be proactive in getting a diagnosis and a treatment so that you maintain your child's quality of life. Any symptom that causes parental concern should be evaluated by your physician. And if your physicians are uncertain, you should know that we in our centers always welcome a consultation from your physicians, because we're here to help them help you. So with that, I'll stop, and I gather we're going to entertain some questions.
Wonderful. Thank you so much. I learned so much from listening there and got so much good information. So I really appreciate it. We do have questions. I'm going to start with, do you think that probiotics help with reflux? It seems to have helped with constipation.
I don't think we have any really good data to tell us whether it does or does not help reflux, either in our children with MECP2 mutations, or for that matter, actually even in healthy children. I think, again, there's a lot we don't know about probiotics in general. There are some very unique settings where we have data that seems to implicate probiotics do something good for some children with specific issues. My comment is always, probiotics won't hurt your child unless your child really has a severe immune deficiency. The handwriting is still out on some of those issues. We know that in the literature, children who have immunodeficiencies may have complications from infections with some of the probiotics. So we know that in MECP2 duplications, some of our children do have, in fact, some propensity to immunodeficiencies. And so I guess I would caution our families and really think about what you do with the probiotics that you have. If your child does not have any known immunodeficiency component, and you want to try a probiotic, then I think it's up to individual's choice. And again, if you do choose to use a probiotic, it's the Lactobacillus reuteri and rhamnosus that seem to be the better choices for gastrointestinal issues. Bifidobacterium is another good one. And so you have to read the labels and know what you're giving your children before you attempt to use probiotics.
Excellent, thank you. Here's another one. Does drink thickener contribute to constipation?
Again, some of my families will say yes. Even some of the, when we recommend things like even the baby rice cereal, for example, some of my folks will tell me the rice cereal interferes and aggravates constipation. Every child is different. And so while in principle, the thickeners should not really affect issues of constipation, I never say never to any of the comments that my parents will tell me. I think all of you know your child best, and every child is different. And so if you think the thickeners cause constipation or aggravate the constipation, then again, it's a matter of your choice, and I would tend to stay away from them. Sometimes if you can find other types of thickeners in your common household items, I will tell families, keep some cream of wheat handy as a thickener. You might want to try adding some of that and see if it helps to your child to swallow as an option instead of a thickener that you purchase over the counter.
Excellent. Can you discuss what you know about any iron absorption issues in kids with MECP2 duplication? And is there a link between milk and low iron absorption?
In principle, we have no data that talks about iron absorption in any of our MECP2 mutation issues. Iron is absorbed high in the gastrointestinal tract. In fact, it's absorbed primarily in the duodenum, which is the first portion of the small bowel. We do know that there are some individuals who have genetic defects in iron absorption, but we do not have any reports, to my knowledge, of these sorts of defects to be present categorically in children with MECP2 mutations, either duplications or deletions. Now, when it comes to milk, the issue with milk and iron is really a problem that we see within the first year of life. So this is part of the reason why people do not give regular cow milk to their children under a year of age. Because in the old days, when I was, for example, your age, all of you, we used to see children who were very anemic. We used to see children who used to have diarrhea, and we used to see children who were swollen and edematous because they all drank cow milk beginning at 6 months of age. And these children would develop a syndrome that is akin to a cow milk protein allergy. So for that very reason, the American Academy of Pediatrics has recommended that no children under 1 year of age get regular whole milk, because cow milk and in that age group interferes with iron absorption.
Excellent. All right. The questions keep coming. This is very good. So, can you talk about babies with MECP2 duplication and low weight due to dysphagia? And do you have any tips for moving from a G tube or solid to from a G tube to solid foods for infants?
So the problem of, I'm assuming this, I'm going to have to interpret this question a little bit. I'm assuming that this is a child who has a button placed at a very early age. And as a consequence, these are the type of children who either never develop their oral feeding skills, or if they did have some ability to suck from a bottle at a young age, they rather lost that skill because it was prudent to use the button as the source for feeding, or the method for feeding these children to a great extent. When you skip the window of opportunity for learning how to feed by mouth as a young infant, it really is much more difficult to acquire those skills as you get older. So it takes a protracted period of time to regain the ability to feed by mouth, even if it is things like purees or very soft, very finely chopped foods. Most of the time, the occupational therapist or the speech therapist who is working with the chewing and the swallowing therapies, they will begin to introduce some of these foods. And it really doesn't matter what kind of food it is. It's really the consistency that becomes very important. And it really is part of the taste initiation before you really make concerted efforts for repeated attempts to feed. The children often undergo first some of the oral stimulation to help the children to learn to desensitize to having some substance in their mouth. And then the therapist will often proceed to just soft tastes of something that the children might like. And oftentimes it's at home when parents are sort of testing the waters and want to just see if their child will enjoy feeding it. And you suddenly discover that your child kind of likes something that the child is given to simply taste at a party or whatever is going on. You often will find that the children, when they stop doing this tongue thrust type of maneuver, that's a good opportunity to really step up the ante to begin expanding the different tastes, and then to begin to expand the texture from the thickened pureed to something with a little bit more of a mashed consistency. Again, it's practice, 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 and patience, 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 patience.
Yeah. Excellent. If you're trying to avoid hard stools, what are some foods to stay away from?
Oh, in my book, there are no foods to stay away from.
Okay. Yeah. You said the ones to do. So I think the question was wondering, well, is there anything that you should avoid?
I
So,
know,
yeah.
I know.
Well, that's good to know, though, that there's not anything you should eliminate from the diet.
I would not eliminate anything from a child's diet. While people, again, are different, and the big one, of course, is milk in the diet, because people will always say, oh, milk constipates my child, I've stopped milk. No, 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 don't do that. Because milk, as I've already told you, is very important for bones. And while I don't have any data really on my boys with MECP2 duplication, we have data across a number of children who have problems in a number of different areas, including children with kidney disease, including children with liver disease, including children with arthritis and bone disease, and including children with gastrointestinal disease. So why should children who have neurological disorders be any different? And so they must have some bone mineral issues. So by all means, we want our children to have milk and dairy products that meet the recommended intakes, and we'll work with our medications to help avoid the hard stool.
Excellent. We have a few questions about salt in food. So is salt in food a concern for kids with MECP2 duplication? Should it be kept like lower than usual? And iodized or non-iodized? Is there a difference?
So the answer to the first part of the question is the children, salt is always an issue in the diet of anybody, insofar as we in the United States tend to keep salt shakers handy, and we eat all the salted chips and dips. And so the real issue is salt is important in the diet. You need salt because it's part of the component that helps to keep, for example, your blood pressure normalized. But the point here is that what we do not need is to have all the added salt in the diet. So there are no specific recommendations for taking away salt from the diet of the children with MECP2 duplication. And in fact, when my families come to see me, for example, and I know their children are getting primarily formulas, we will always do a salt calculation in the diet, because we know that children have an average need of about 1 to 2 milliequivalents per kilo per day. And I know most of you won't know what that translation means, but it becomes relevant to me, particularly when my children are on formulas that we have manipulated. Oftentimes when the children are a bit overweight and I need to reduce calories, I do have to be careful about salt in the diet. And very often we will be adding some salt in the diet, because too little is just as bad as too much. So it's like that with everything that we talk about in nutrition. Too much and too little are just as bad. We want you on that U part of the shaped curve where it's in moderation.
Excellent. Very good. Let's see. We have a question about daily Miralax. So does the need for Miralax, does it decrease as a child gets older? Does it change over time? Will a child usually need it their whole life?
So the answer to your question is depends. By and large,
Yeah.
we know that if you have constipation as a child, we know that the constipation issues usually get worse over time. So if you need a laxative as a young child, usually you will need laxative throughout the rest of your life. Now, The Miralax, as an example, yes, I'm always changing doses on the Miralax. Miralax can vary depending on what you eat. Miralax can vary depending on the child. My guess is Miralax can depend upon the different types of mutations that the children will have. And certainly the dose of Miralax can depend on the full moon. So that means I don't know why it varies, but it varies at times.
Yeah.
And as I said earlier, sometimes the Miralax tends to be not the best choice of medication as my children change over time with growth. Yes, I tend to use Miralax throughout life. Yes, you will probably need it forever, or at least you will need to change to some other laxative. Or in some instances where my families prefer to just use a simple enema, for example, they oftentimes can then use dietary measures and just use daily enemas. We here in the United States tend not to like to mess with the butt, as I tell families. And so we tend to stay away from the enema therapies unless it's what you prefer. My European folks, they all love to use lavage. And so whatever works for you, the bottom line is I don't want to see an impacted child. So whatever works, we use combinations oftentimes, but yes, laxatives in general are needed throughout life.
Excellent. And we just have a few minutes left. So I do want to ask you about, is it better to use low fat or full fat dairy? Do you have any recommendations about that?
So the answer to that question is depends where your child is on the spectrum of the BMI curve. If your child is a perfect weight for height, I would use the regular whole food, regular fat, because in the end, what you are doing is a balance of good quality dietary intake. If your child is underweight, we always want you to use the regular fat milk products. If your child is overweight, you may need to reduce to a 2% or a 1%. And on rare occasion, we'll do a skim milk type of variety. But the bottom line is real food is good food. And real food has a much better taste than some of the manipulated low fat stuff. So I'm always happy with regular food because I think it tastes better. And you want your children to enjoy life just as you do. So real food is good food. But again, pay attention to the overall BMI curve.
Excellent. And then I want to ask you one last question. I think is what we'll have time for. For some of our families who are coming to us from other countries outside of the United States, and I've heard this from multiple families, this question that a mom is asking, that it's just really hard to get all the dots sort of connected in their system. If a child has the reflux and chewing issues and constipation and bloating, do you have any recommendations for advocating or how to help that, doctors in other locations sort of bring everything together?
Well, there is no magic bullet beyond having your, having your physicians email us. I receive emails from around the world. I oftentimes will see children from around the world. We have connections from around the world. When I've traveled abroad, particularly to Europe or to Australia, and even South America, I've met the physicians in different places who are relegated to taking care of children with MECP2 mutations. So many people know about us in the United States. There are people around the world who are doing work in the MECP2 mutation area, but oftentimes your general practitioners are not those folks, and they don't always have the experience of trying to pull everything together. Those of us here are more than willing to entertain emails. if push comes to shove and we have visitors who come to this country, we always are happy to visit with them. We are always happy to take phone calls. If they're here in this country, we're even happy to take international calls, which we've done at times. But I think by and large, communication by email with your physicians when they have questions, I think is probably the best recourse. They can always go to web-based papers in our literature, in the medical literature, but oftentimes that doesn't totally fill the gaps when it's the particular child who a physician needs to have some help with. There are webinars that are out there among the MECP2 mutation community. So oftentimes the webinars can be helpful as well. And it's the links among families where you have your good information resources. There's a lot of misinformation out there, as you all well know, in this world today. Misinformation abounds on the web as well. If you can go to your trusted sources and interconnect with your good quality information resources and families who you know will help you to get answers to the questions you have, I think those are your best choices.
Excellent. Thank you so much. There's information on the screen. If you need any more information from this webinar, if you want to submit ideas for future experts to talk with, we have our email up. And Dr. Motil, this was such a pleasure. Thank you for being here with us today.
My pleasure. Thank you all.
Wonderful. All right. I think we're going to stop the recording there. And thank you to everybody who's here with us